Hello everyone, I am Dr Anupam here and today we will discuss how to maintain a brain dead patient till the time of organ retrieval. Let us discuss. A patient who is having severe brain injury, first there will be medullary ischemia. So to protect the brain, the CPP has to write CPP is cerebral perfusion pressure, and to do that there will be autonomic storm. But this autonomic storm is transient and it's a part of what we call as Cushing sign. Cushing sign is triad. What is the triad? We will deal with two of its components. One will be hypertension, another will be bradycardia, right? The next step will be, there will be spinal cord ischemia. And uncal herniation. When it happens, there will be loss of cardiac stimulation and stoppage of autonomic storm. These two things will happen. So that will lead to hypotension. Right. Thirdly, there will be loss of posterior pituitary function that will lead to stoppage of secretion of ADH that will cause polyuria, which is by definition urine output more than 200 ml per hour for more than 2 hours, and urinosum will be less than 200. It will produce hypovolemia and hyponatremia. Then there will be loss of thermoregulation and decrease metabolic function, and that will produce hypothermia. Then last but not the least, there will be blunting of HPA axis, hypothalamus, pituitary and adrenal axis, and thyroid dysfunction, which will produce hormonal dysregulation that can exacerbate hypotension and hypothermia. So these are the things that are produced when patient is brain dead, right? Now we'll deal each and every part of it so that we can maintain the patient in a very stable condition, right? So first, coming to the part 1, when there is hypertension and bradycardia, because it is very transient, the nature is transient. So the guidelines is do not treat it. If patient is hypertensive, bradycardia, do not bother about it, do not treat it. If at all you have to treat it, use short acting agents like GTN, SNP, Lobate, Hydralazine, etc. Do not use long acting agents here because it is immediately followed by hypertension. If you use long acting agents, then the hypertension can be sustained and it will produce organ dysfunction, right? Also, if you want to treat bradycardia, use epinephrine or isoproterenol only if it is required, otherwise do not use it. Second, coming to hypotension, this is the major thing that we have to treat. Hypertension and hypovolemia both treated together. We have three options. First is IV fluid. What kind of IV fluid will choose? You usually choose half NS, Ringer's lactate, plasmalite. If you want to conserve the volume, restrict the volume, you can use even albumin, but not colloids, not NS. Why? Because here you can see, it is producing hypernatremia. So we have to avoid any solution that can exacerbate this hypernatremia. That is the reason why we choose HAP-NS, Ringer's lactate or plasmalite. Albumin usually do not choose because it contains high sodium, but you can use it in case of when you want to restrict fluid. Right? Then second will be vasopressors. And what is the drug of choice? Vasopressin. For obvious reason, because posterior pituitary is not working, so vasopressin is not being secreted, so use vasopressin first. This is a part of hormone replacement also. So it's the drug of choice. And second will be epinephrine. As you have seen, the autonomic storm or the catecholamine produces myriads of signs and symptoms. We have to avoid any kind of catecholamines, and vasopressin help us doing that. So the advantage of vasopressin is it is catecholamine sparing. Also, it prevents diabetes insipidus, which is inevitable in this patient, most of these patients. Right? Then third will be hormonal replacement. Already one we have discussed, that is the vasopressin. Other hormones we will discuss in our last part of discussion. Then coming to hypernatremia, we have already discussed. Avoid high sodium containing solution and treat DI. How to treat it? Generally you use desmopressin. So the dictum is, if hypotension plus polyuria, use vasopressin. If no hypotension but polyuria, use desmopressin. Because desmopressin do not have a vasoconstricting effect. So, using a dose of 10 mcg per puff QDS, and the target will be to maintain urine output 100 to 200 ml per hour. Remember that desmopressin do not cause vasoconstriction. So if the patient is having hypotension, at the same time polyuria, use vasopressin. If there is no hypertension, use desmopressin. Right? Now coming to hypothermia, the best treatment is to prevent it. Prevent it. How to prevent it? Usually we do surface cooling. Otherwise, if the temperature becomes less than 30-40 centigrade, at this time core temperature monitoring active warming using humidifier, using fluid warmer, using bear hugger, all these things, right? Now last, coming to the blunting of HPA axis and thyroid dysfunction. Here you use what we call as hormonal resuscitation. Hormonal resuscitation. It has 4 components. Number 1 is vasopressin. We have already discussed. It is usually used in a dose of 1 to 5 units per hour. Second will be methyl prednisolone. That will be 15 milligram per kg body weight per day. Third will be thyroxine. Usually use T3 tablets. That is 300 mcg to 400 mcg TDS. Then we use insulin. Our CBG target will be 80 to 150. So in this way we maintain a patient who is going for organ retrieval.